thank you all for joining us today for the release of the Bipartisan Policy Center's report, Optimizing the Medicare Home Health Benefit to Improve Outcomes and Reduce Disparities. I'm Bill Hoagland, Senior Vice President here at the Bipartisan Policy Center. I have the pleasure of working with our health team on a number of their issues. BPC has a history of advancing policy recommendations to improve care for individuals, particularly with chronic illnesses. And just last month, we released a report, a policy roadmap caring for those with complex needs, which summarizes a decades-long work that we've done here on putting forth various policy recommendations. You can find that on our website. Dr. Fauci yesterday clarified some earlier remarks he made this week, suggesting at least in this country, we are transitioning from a pandemic phase of COVID into a more endemic phase. And yet we know COVID and its variants has had and unfortunately will likely continue to place strains on families and patients, and particularly health workers in hospitals and nursing homes. Addressing the pandemic early on, Congress passed and the administration introduced a number of temporary flexibilities to address COVID by allowing new types of care to be delivered through the home setting. So the profile of home-based care was heightened by COVID, but I would note that the trend toward home care preceded the pandemic. For years, we've seen a shift of health services out of higher cost facility settings, and we expect this trend to continue with the aging of the population, I being one of those, of course. Payers have led the charge also to increase home care. So recently, United Healthcare and Humana made a major investments in home care. They purchased two of the largest home care agencies in the United States, LHC and Kindred, respectively. And overall spending on healthcare last year was about $125 billion, but that's expected to nearly double in the next few years. So a broad discussion about home care continues, particularly as it relates to something the traditional Medicare home services, we think deserves some special attention. And that's the purpose of this discussion today. In 2019, Medicare spent about $18 billion on home health services and served about 3 million fee-for-service beneficiaries. Now, that's a relatively small percentage of overall Medicare spending, something less than about 3% and less than 5% of all Medicare beneficiaries. But we believe that given the clear changing trends in our healthcare delivery system today and the increasing demand for home-based care, that there are opportunities to address the current Medicare home health program, which we think can likely and does create some inequities and barriers to those who need care there in their home. Now you're going to hear from some about those opportunities and recommendations from our expert panel here shortly. But let me just make this one point clear. We at BPC acknowledge that Congress in the original 1965 Medicare Medicaid Act did not intend for traditional Medicare to cover long-term care. And we understand the importance of maintaining the current benefit structure. Let me close off here by on behalf of BCC, extend our thanks to the Commonwealth Fund for their support of today's event and this report. I also want to pay particular thank you to Dina McDonough, the lead author on this report, who unfortunately left us from BPC just the last couple of days ago, hired away by the administration for a position at CMMI. Sad for us, but good news for the administration. And now I'd like to turn this over to Gretchen Jacobsen, the Vice President of Medicare for the Commonwealth Fund, for some opening remarks. Gretchen joined the Commonwealth Fund in 2020 as Vice President of their Medicare program. Previously, she was at the Kaiser Family Foundation, where she served as the Associate Director for the Foundation's program on Medicare policy. So Gretchen, thank you again to the Commonwealth Fund for your support, and I turn it over to you.
Thank you so much, and welcome to everyone. We're gathered here today to talk about the Medicare home health benefit and how it can be improved for people on the program. Home health care plays a critical role providing care to patients recovering from acute hospitalizations and to frail, community-dwelling, homebound patients referred to home care by physicians. Patients overwhelmingly prefer care at home, and evidence suggests that home health services from high-quality home health agencies frequently result in better outcomes. Under the law, Medicare beneficiaries who have trouble leaving their home are entitled to home-based skilled care, such as physical therapy or occupational therapy, and this coverage is available even if services are expected to continue over a long period. They are also entitled to help from a home health aide with activities of daily living to maximize the effectiveness of the skilled care. However, the majority of Medicare beneficiaries eligible for help from home health aides do not receive it. For most beneficiaries, the assistance from home health aides is often needed to make skilled care at home a real option. Without coverage of home health aides, beneficiaries either pay out of pocket for that care, which many beneficiaries cannot afford to do, rely on unpaid caregivers like spouses or children, which many beneficiaries don't have, or are forced to receive care at a nursing home or other institution instead. People also need access to the benefit when they are very vulnerable and they need the care to be available when they need it. But changes in Medicare's payments and regulations designed to limit fraud have led to misunderstandings about what is covered. This raises questions about appropriate coverage and the equity of who truly has access to care at home and who does not. As you will hear today, this is an issue where the benefit is clearly defined in statute, but there is disparate access to the benefit and profound inequities in access to care. As part of the body of work looking at this issue, the Commonwealth Fund supported the Bipartisan Policy Center to examine the mismatch between the home health benefit provided under statute with the current landscape of home health coverage today. We asked them to identify administrative changes and other initiatives that could help improve access and make Medicare home health care more effective and equitable. We look forward to hearing the recommendations of the Bipartisan Policy Center, and I will now turn it over to Lisa and her colleagues. Thank you very much.
Thank you, Gretchen, and thank you to everyone tuning in today. My name is Lisa Haratunian, and I'm an Associate Director for the Health Program at the Bipartisan Policy Center. Today, I'm joined by 3 panelists, and together they will bring a range of perspectives and valuable expertise to our discussion on the Medicare home health benefit. As we begin the panel discussion, I will first introduce each of our panelists, and then we will dive into some questions. Toward the end of the panel discussion, we will respond to some audience questions, so we encourage all of our viewers to submit their own questions throughout the panel discussion using live chat on YouTube or on Twitter by using hashtag BPCLive. Now, the first panelist that I would like to introduce and welcome is Dr. Chaney Fabius. Dr. Fabius is an assistant professor at the Johns Hopkins Bloomberg School of Public Health. Dr. Fabius is a gerontologist and health services researcher with an interdisciplinary background consisting of training in gerontology, human development and family studies, and public health. Her research informs aging and disability policies to reduce healthcare disparities and improve health equity for older adults and people with disabilities using long-term services and support. She has a PhD in human development and family studies from the University of Connecticut, and she completed a 2-year AHRQ-funded T32 postdoctoral fellowship in the Center for Gerontology and Healthcare Research at the Brown School of Public Health. Next, I would like to welcome Ruth Katz. Ruth is the Senior Vice President of Public Policy and Advocacy for Leading Age. Prior to joining Leading Age, Ruth was a longtime executive at the U.S. Department of Health and Human Services, with a focus on development and execution of policy research and analysis for programs in aging, long-term care, and disability. She held dual roles as the Associate Deputy Assistant Secretary and the Director for the Division of Aging and Disability in HHS's Office of the Assistant Secretary for Planning and Evaluation and the Office of Disability, Aging, and Long-Term Care Policy. Finally, I would like to welcome Ann Tumlinson. Ann is the founder and CEO of ATI Advisory, a national research and consulting firm that shapes public policy and business strategy to reform care delivery for individuals with complex care needs and their families. Ann previously worked as a healthcare advisor to Congressman John Lewis, and then as the lead for Medicaid program oversight at the Office of Management and Budget. She joined Avalier Health in 2000, leading the firm's provider practice and developing business intelligence products for 14 years. Ann also founded and runs Daughterhood, serves as a Nexus Fellow, and was named an Influencer in Aging by Next Avenue. So thank you to each of our panelists for joining us today to talk about optimizing the home health benefit. The home health benefit is limited to Medicare beneficiaries who meet specific criteria. They must be homebound and in need of skilled care for short periods of time. It is often used to tide a patient over just until they can leave their home safely to get outpatient care. But the benefit has been unsuccessful at meeting the needs of certain Medicare beneficiaries. Some believe that one factor influencing the effectiveness of home care for beneficiaries with chronic illness or complex conditions is the availability of home health aides to provide personal care assistance. Without these services, beneficiaries must rely on unpaid caregivers who may be untrained. And there is some evidence to suggest that these beneficiaries may be more likely to suffer worse outcomes compared to beneficiaries who receive care from well-trained caregivers. Today, our panelists will weigh in on how a benefit designed to address short-term rehabilitative needs can better meet the needs of patients with chronic or complex conditions. This largely comes down to, first, Medicare covering home health services for beneficiaries with chronic illness, cognitive deficits, or other complex conditions when appropriate. And second, whether agencies deliver the optimal mix of services. We will also discuss how limiting access to these services contributes to racial and ethnic disparities. So now let's start the discussion by talking about eligibility and coverage under the benefit. This first question is for Ruth. Ruth, the Medicare home health services are different than other services. The eligibility criteria are very specific. In addition, there's a history of fraud and abuse in the home care sector. How have payment policies changed to prevent fraud, and how have agencies adapted to this change?
Well, Lisa, I want to start by first commending you and the whole BPC team for a thoughtful and very well-researched brief, and for today's milestone, releasing it. And again, thank you for this opportunity to be here to talk about it. I know it took a village and a long time, I'm going to guess, to get to this milestone today, but this is just the beginning of a really important conversation, and I want to thank you for launching that conversation. There's a history of fraud in very specific places, right? But so often government efforts go to the worst offenders, a small group of people of providers that are the worst offenders. And the idea is protect the taxpayer dollar. I get it, I share that goal. But sometimes that harms the most vulnerable consumers, and it creates huge equity issues. And we see that play out over and over again. To your question, in January 2020, that was a long time ago, a long COVID time ago, CMS changed the home health payment methodology to get away from therapy-based thresholds, which were really a major contributor to a lot of that fraud and abuse that we saw in the former system. So we used to have agencies avoiding patients who didn't need therapy visits, working hard to find reasons for more therapy visits so they could bump up their payments, right? CMS also reduced the length of episodes by half, 60 to 30 days, reduced payment for subsequent home health periods. So that meant that people that needed more support for longer periods of time could be left just high and dry, right? By agencies that looked at their bottom line. And you can't blame them, right? It's just another example. You get what you pay for, right? You design a financing system and that drives how a program is implemented. Another recent change that I think has been hard for providers was the end of the request for anticipated payment. So under the previous system, you could get a percentage of your anticipated payment to float the cost of the full episode. But now you don't get any payments till the end of the 30 days. So we're seeing increased scrutiny of services provided, which means an auditor could deny the claim, and then you get nothing to show for the services. It's really tough situation for providers to be in. And I want to say especially not-for-profit home health providers that are operating on thin or non-existent margins. And it makes them hesitant about, to be honest, about complex patients.
Thanks, Ruth. Great point. This next question now is for Anne. Anne, how has the structure of the benefit affected access for individuals with complex needs and their ability to access the home health benefit? And have the resulting guardrails disproportionately affected Medicare fee-for-service beneficiaries with chronic illness?
Sure. Great. Thank you for that question, and echoing everything that Ruth just said about congratulations on this work, and especially huge thanks to the Commonwealth Fund for having the sort of the vision to begin to tackle this. So, just building on what Ruth just said, that there's been a tension in this benefit since it was practically created, or certainly since the 80s and the 90s, when it started to, spending started to really accelerate after the implementation of the hospital inpatient prospective payment system. So, we have this benefit. So first of all, I've been working on this benefit forever, and I find it incredibly confusing, and even have more recently been, we'll talk about this later, I'm sure, a consumer, and just astonished at the complexity here. You have benefit, so you have a prospective payment system that's episodically based, where presumably we're saying to providers, like, this is a group of people who are eligible for this benefit, and here's your payment, and here are the services. You collect the information on the OASIS, you do an assessment, you determine what they need, and you deliver to them what is best going to meet their needs on a person-centered basis. And yet, then we have all of this behind the scenes kind of process and sort of evaluating and scrutinizing claims that actually kind of thwarts the whole concept of a prospective payment system for an episode. Like, it makes no sense to me. We should be 100% moving in the direction of giving providers flexibility within some certain parameters, and then measuring for outcomes, measuring for patient satisfaction, and measuring things that matter to beneficiaries. So this benefit eligibility criteria is sort of crazy, because it's like you have to need, so it's a very long list of things that are all unrelated to each other. It's very primitive. It's like you have to need intermittent skilled care. What does that even mean? You have to be homebound. You have to be all these other things. It's like we came up with all of this stuff to sort of kind of create as many gates as we could to prevent this, concern about like a woodwork effect, and what it's, and just what Ruth just said, it's so much better than I can, and so beautifully. It's like, we've essentially made it really, really hard for anybody to access anything meaningful. So I think what I would say is that we are way, way overdue for coming up with a new policy about, and this is very ambitious, but I'll just say, like, who we serve with home health benefits, how we identify those beneficiaries, and how we qualify them for services, and doing it in a way that's really clear for the agencies, clear for the beneficiaries, clear for the referral sources. Because the fact of the matter is that the majority of Medicare beneficiaries who have complex care needs live at home or in the community. And so their needs for things like skilled nursing are more complex, skilled nursing at home are more complex than ever. And we've got to have a benefit that, we've sort of changed the payment system, but we haven't changed sort of all these gating mechanisms to allow that payment to incentivize the agencies to do what they presumably could do well if they weren't sort of in this weird environment with all of these antiquated and primitive rules.
Thanks, Anne. Those are some very important points. So this next question now is for Dr. Fabius. In this report, BPC recommends additional data collection to identify whether claims for certain populations or conditions receive a disproportionate number of denials. How has the structure of the benefit contributed to racial and ethnic disparities in the home care sector? And also, what data should CMS gather? And are there specific data points that would be most valuable for identifying causes of racial and ethnic disparities?
Thank you, Lisa. And echoing the comments of my co-panelists, Ruth and Anne, excellent. The report has been excellently put together. I just want to say that addressing some of these issues may take some backtracking, because there's such little consensus and understanding and agreement on what happens at the time of referral to home health. There's so much variation in the way in which Medicare beneficiaries are referred to home health. Some people are provided a list of agencies to select, the best agency for their family. Others are helped a little bit more via hospital staff or nursing home social workers. So the challenges really do sort of start with the referral process. I will say that the recommendation for additional data collection to identify some of these differences that you all have suggested is a good one. We know that the delay in the start of care is associated with rehospitalization, that disproportionately impacts racial and ethnic minority groups. We also know that there are racial and ethnic disparities in the start of care. We don't know really why that's the case with Black Medicare beneficiaries and Hispanic Medicare beneficiaries more often experiencing delays in starts of care than their white counterparts. I think that we need to examine the reasons many times behind either refusal or denial. What sort of information as well is communicated from hospitals and nursing homes to home health agencies, whether it's complete information, how people are able to really information gather about the potential clients that they're going to be serving. We know that there also are concerns about the safety of communities that people are going into. And that is one challenge that people might experience as well as they're making decisions about who is willing to serve in particular communities. And so I think my suggestion is that as a researcher, there has to be more research done to really understand, what's going on. Why is it that, we're seeing these delays in starts of care? What are the driving factors? And I think that your first step of, recommending this additional data collection is an excellent one.
Dr. Fabius, great point. I want to turn next to discussing payment and quality metrics. But before we dive into that, I want to remind our audience that you may submit questions using live chat on YouTube or on Twitter by using hashtag BPC Live. All right, now let's turn to our next question, which is for Anne. Anne, many of the current payment policies have reduced access to home health aides. How does this impact the recovery of those with chronic illness, cognitive deficits, or other complex conditions?
Thanks, Lisa. That's the big question. So for most beneficiaries who have complex care needs, what that means is, the needs are kind of cross-cut, kind of what you would think of as traditional medical needs, but also with needs for support, social determinants of health, certainly things like, nutrition, transportation, housing, but also, and this is the thing that I feel like policymakers, particularly in Medicare, kind of miss or forget, and BPC's been so wonderful about highlighting through its work, is having a need for support in daily activities like bathing, dressing, eating, getting in and out of chairs, all of those things are, are kind of critical, certainly to the recovery from an inpatient hospitalization, but also, issues that individuals with skilled and, highly kind of clinical needs are also experiencing. And if you don't address those and provide support for those functional and cognitive deficits, it's impossible to deliver a meaningful skilled or medical benefit in my view. And so beneficiaries with complex care needs need support around the basic activities of daily living, and they need, sometimes that's restorative as they go through the process of rehabbing from an acute episode. Sometimes it's just about kind of integrating those with sort of ongoing at-home skilled support. So not having that support jeopardizes safety. It puts individuals at risk for falls, it puts them at risk for hospitalizations. And I would just note, it's especially challenging for individuals who don't have family caregivers on site to provide support. So if they don't have access to a home health aide, for all practical purposes, the home health benefit is relatively meaningless. I mean, it's you could have, kind of therapy, maybe a skilled nursing visit here or there, but you're not actually supporting the individual around kind of the fundamental needs for functional and cognitive support. So, maybe I'll just also add that especially when I look at post-acute care, and there's a lot of discussion right now about making sure people can age in place, age in community, reducing reliance on nursing homes and institutional settings, but really effectively and practically the only site of care where a Medicare beneficiary can receive daily skilled and unskilled services is in a skilled nursing facility. So I think, again, we kind of have to think about more broadly from a post-acute care perspective, but what do we want, what do we want the home health benefit to do? How do we want to design it so that it is flexible in meeting, the care needs of the individual Medicare beneficiaries? To what extent do we want to drive people with daily skill needs into the SNF benefit versus home health? This is a perfect time for us to be having this conversation.
Very true. Thank you, Anne. This next question is for Ruth. What would have to happen to increase the availability of aid services or otherwise impact the availability of an optimal mix of services?
That is the $64 question. How do we do this, right? I think anyone who can possibly do so needs to shut down their computer and go home and start having babies, because we don't have enough people. So that's one of the big and central points. I want to go back to what we were talking about in terms of the construction of the benefit as it is now. And I agree with Anne. We want people to have the best lives possible and get the best services to meet their needs. And that also changes during a person's lifetime. It's really important to kind of keep that in the background. The home health benefit was constructed and paid for based on rehab, skilled care. So improvement isn't a requirement, right, to qualify, but the payment structures currently in place incentivize improvement. And so do a lot of the quality measures. And changes in the structure need to consider how providers are going to pay for that, right? How are they going to pay for more aid hours, as well as measures that look at stabilization? So I cannot answer this question without talking about the workforce crisis, and you can't ignore it. We've been looking at the situation here at Leading Age, and almost every policy issue we talk about comes back down to the workforce crisis. We have to resolve that. Increasing, retaining, recruiting workforce. Agencies, if they can't do that, can't make good on any of the promises to increase aid services. So something like a staffing ratio, while it sounds good, isn't realistic, right? Without the money to do it and the people to do it. I can tell you, for Leading Age members, most of them, all of them say, I would love to hire people. I would love, and this is across the continuum, not only in home health. I would love to have applicants for the jobs that I post. It's more and more the case that just about everything is workforce. And it really is a 911 now. I heard a speaker just a few weeks ago who said if everyone in this room had a baby right this minute, we wouldn't have enough people to fill all we have. And then even so, those babies aren't going to be 18 for, 18 years. So they won't be workers. But with all these caveats, quality measurement, I think, is probably a good way to begin incentivizing change. So just let's set the workforce crisis aside for just a second. Increasing the availability of aid services has to come with recognizing home health's greatest failing, which is its reliance on unpaid family members to be an essential part of the system. And should it be that way? The current home health assessment identifies if there's a willing and able family giver, and if there's not a family caregiver present or one willing to help, home health agencies could be held accountable for providing aid services through a quality metric like percentage of beneficiaries with no natural supports who received aid visits during the home health period. But it would have to come with funding and available aids.
Very important point. Thank you, Ruth. This next question is for Dr. Fabius. In this report, BPC recommends developing and implementing measures with a focus on reducing racial and ethnic disparities and explicitly linking payment to meeting performance benchmarks. Would measuring time to first visit be impactful? And are there other outcome measures that CMS should consider?
Thank you. And I just wanted to, before I address that really quick, just piggyback on something that Ruth just said. I lift up all her comments about the workforce, but also the reliance on family and unpaid caregivers. Racial and ethnic minority groups have larger caregiving networks. And so that may be some of why we are seeing some of the differences in allocation of services. But the assumption is that the caregivers are not experiencing as much strain or stress because there may be more folks to split the load, so to speak, quote unquote, among. And that's just not always the case, right? Because racial and ethnic minority groups are also working and managing less financial resources. There's a number of different challenges that they experience that may have their caregiving situation look much different than others. But I wanted to comment on the question that you just asked. First, we know that racial and ethnic minority groups, Black and Hispanic groups especially, are often receiving services from agencies that have trouble meeting performance benchmarks, so lower quality agencies. But I also want to lift up the fact that these are not just bad apple agencies. They are often under-resourced, they're smaller. They have the huge issues, when we're talking about workforce. If they look anything like the Medicaid home and community-based service agencies that I study, they range in size, they range in structure, they range in the availability of workers. And so there are a number of challenges that they experience. So I think that linking payment to benchmarks can be there can be pros and cons to that. And it may be difficult to compare agencies that are already lower quality to others that are not. There may be an opportunity to measure their change over time, and perhaps that's the way in which we evaluate their improvement. I do think that time to visit is an important aspect to consider, but I also urge the consideration of what's preventing that. Going back to my first comment and digging a bit more around, like, what's the reason? If I don't have the workers, I can't send anybody out there, and that's not intentional. That's just that we don't have the staff. The other thing is that, functional improvement in terms of, measuring performance benchmarks is always hard because there are people who, improvement looks different, right? It's relative to the person who has the need or is receiving services. So that will vary on by situation and circumstance. But yeah, I would just say, that the agencies are oftentimes doing the best that they can. And I think there has to be careful consideration about what linking payment to performance benchmarks really means.
Thank you, Dr. Fabius. I want to turn now to talking about service availability. And this next question, again, is for Dr. Fabius. The beneficiaries belonging to racial and ethnic minority groups experience more adverse events, a greater decline in functional status, and worse experiences when receiving home health care compared to white beneficiaries. What are the major factors which influence the quality of care individuals receive?
Thank you again. I just, echo the comment. Some of the comments that we, have already made is the structure and processes of the organizations, the referral processes done at the hospital level or the nursing home level. I raised up sort of the willing to serve in certain areas, like geographic areas. In a previous life, I was a care manager for the Connecticut Home Care Program for elders, and I can tell you that that's a real concern of people. And so whether there's support in, getting folks to where they need to go so that they can address, help people in their homes and communities in an environment that they feel safe, that's, really important. But I would just say that additional family support is also something that should be highlighted. We know that when the family breaks down, everything falls apart. And so the reliance on caregivers who oftentimes understand but don't really understand what they're getting into when they're signing up for home health or any other long-term service and support, I think it's a recipe sometimes for disaster. So I think that we got to figure out a way to better support families where they are.
Great point. Thank you. This next question now is for Anne. BBC recommends that CMS establish some staffing standards for home health aides to ensure they are available when appropriate. What impact would that have in increasing access to home health aides for Medicare home health recipients?
Thank you. But I want to respond to that, but I'm laughing because every time Dr. Fabius talks and you guys pan back to all of the panelists, I'm always shaking my head really vigorously like this because I just so agree with everything she's saying, and especially the part about the family caregivers and I definitely hear through the network that I'm part of just, an enormous amount of burden that falls on family caregivers as soon as the medical care moves into the home setting. And we talk about this a little bit more in a bit, but it's this benefit, the way it is structured now and the way it is delivered now, all aspects of that from, the statutory eligibility criteria and services all the way to the way that it's, the compliance issues are handled on the claims review, essentially kind of leaves that family caregiver very much in charge of everything, and particularly very clinical medical tasks. So, and we're not just seeing this in home health, we're seeing this kind of across the board. But we have to just be so intentional going forward about what kind of the various roles are and what we expect. So on staffing standards, I think staffing standards can always be helpful. And particularly if they're sort of flexible and recognize a variety of different scenarios and situations, that they can sort of help normalize and communicate what the expectation of service delivery for home health agencies is, and give them kind of a safe zone where the delivery of these services doesn't somehow trigger our claims denial. I feel like I don't really understand, like we have the worst of all worlds in the sense that we've got this, again, this episodic payment that's over this kind of long period of time relative to, say, other episodic payment systems. And then, in theory, should enable the agencies to flexibly deliver a range of services, deliver person-centered care. But what the BBC and Medicare Rights Center have shown is that this claims payment process is evaluating the appropriateness of services delivered within this episodic payment. So, and now we've got PDGM, which is it's supposed to be person-centered. So I think we've got a lot of sort of conflicting messages to agencies and to beneficiaries. And so having some standards in place around particularly the delivery of services for home health aides can be helpful again, taking into account everything that Ruth has said so well about the workforce issues. So yeah, I think we have to communicate our expectations.
Thanks, Anne. And I'll note that BPC's report does acknowledge some of the challenges associated with staffing standards that you and Ruth raised earlier. But thank you again for highlighting some of the value that those staffing standards could have. So next, in this last part of our discussion, before we turn to the audience questions, let's talk about the beneficiary and caregiver experience. This next question, again, is for Anne. And now, Anne, you have worked on the policy side of home care for a long time, but more recently, you wrote about your experience navigating home health care services as a caregiver. What was the most surprising thing about the process, and what caused you the most frustration?
Oh my gosh, I don't even know where to start. We had 3 different home health agency providers over the course of 3 months. And so we went through an OASIS assessment 3 times. And it was, as somebody who's like, yes, data, yes, assessments, yes, care plans, we were just like, are you kidding me? How many times do we have to answer these questions? And, for somebody who's interacting with the healthcare system a lot, like my father was, we're answering these questions at the physician office. We're answering the same questions in the hospital where, we just feel like always you're being asked to start all the way over with the history. And there's just no sense of continuity. There's no sense of connection across a coordination of any kind. And I guess that didn't super surprise me, but the thing I think I found just the most astonishing is that in our situation, my father had really complex medical needs. If there was a poster for somebody who should be getting skilled nursing at home on an intermittent basis, it's my dad. And we couldn't get a skilled nurse. It wasn't even so much a workforce issue as it just was sort of like, we got lots of therapists, but we could not get a skilled nurse. And so we had a wound dressing changes. We had, PICC line flushes. We had oxygen tank. So we were home, medical care at home. And my 81-year-old mother was basically doing all of it. And I had to push very, very hard to get even one skilled nursing visit a week. And I was told many times, that's all you can have. So, I was like, what? This is a skilled nursing benefit. So, and maybe just finally, the final thing I would just say is I was really, really surprised about how hard the scheduling was. I felt like I was managing a switchboard. And it was like, it's like, if you're in a hospital, people are coming back and forth to you're getting like, oh, here comes a nutrition person, here comes a therapist, and you're just sitting there and that works, right? That's how they treat your home. So, it's like, hey, I'm 10 minutes away. Can we stop by? And we have the nurse and the therapist there at the same time. And they're just, and I'm on the phone constantly trying to figure out when people are. So I think we need technological solutions that will really help sort that. But, these were good home health agencies. This was the norm is my understanding.
Thanks for sharing that, Anne. So this next question now is for Ruth. A recent Avalier study found that the majority of personal care assistance provided to beneficiaries after hospitalization is not delivered by home health agencies. Other studies show worse health outcomes, including more falls and emergency department visits, and higher Medicare spending when assistance is provided by family or other untrained caregivers. What is the role of agencies in delivering caregiver training, and how do they fulfill that responsibility?
Yeah, let me start by saying one thing in response to what Anne was saying, and kind of what we've all been talking about, which is that when this benefit was originally, when Medicare was created, life was different. People were different. People didn't live routinely into these old ages that we are living to now and that we'll continue to live to. And they didn't come home from the hospital with the kinds of needs that they have today. So it is a good thing that providing training for family caregivers is part of the conditions of participation for home health agencies. And that plan of care for family members should probably specify what training and education the caregiver is going to need. The home health assessment goes a little deeper with questions on providing drug risk education, but it doesn't go further into the very things you just asked, Lisa, education and training on things like falls prevention, right? And that's really what you need to have to do this. Home health agencies might provide some more education on falls prevention or bed transfers, but again, that's not explicit in the assessments. Maybe we need the assessments and the quality measures to, again, and I think I've been hearing this between the lines all along, to match up to what people need and what families need and what families can deliver. Right now, some of that is just left up to the home health agency, determine the risks, assess them, and it's not for every agency an equally high priority, right? I want to say about family members, they're not medical professionals, and that gets, as I said, more and more complicated. They're not paid to take care of family members. We know that more than half of them are working already, to Chaney's point earlier. When an episode of care is 30 days long, you have fewer visits from professionals for training opportunities, despite Anne's revolving door, and I know that that's true too. On top of coordinating training, it's a job. I mean, I think that's what Anne was saying. It's going to be hard to provide quality care for this person that you love, that you want to give the best life, and you don't want to mess up the actual care. You want to give the best care too. So I don't know, Anne's example about beneficiaries who don't have a family caregiver is the other one we really have to keep in mind. I want to just say, and I know I'm speaking to people that are already converted on this, but as I think about all this and think about, you know, how are we going to staff and what are family members supposed to do, it really is driving us firmly into an important point you make in today's report, and one you made loud and clear in the health policy roadmap not too long ago. The nation is just going to have to face the facts of the demographics and enact meaningful long-term care financing reform. We can demand more from family members. We can keep on trying, you know, if they're available. We can retrofit and jerry-rig home health and Medicaid, but it's only going to go so far. And at some point, these strategies are going to fail us, right? I really want to commend courageous legislators like Tom Suozzi and Frank Pallone for starting the conversation, for offering up proposals, at least, for comprehensive financing reform for long-term care, because we're kind of talking all around it, but that's where we also need to be looking for solutions.
Great point. Thank you, Ruth. Now we have a little over 10 minutes left, and I will now want to open it up to audience questions. So again, you may submit your audience questions using live chat on YouTube or on Twitter by using hashtag BPCLive. This first question is from YouTube. What are your thoughts about the patient-driven groupings model of reimbursement? And now I'll open this up to all of our panelists. Feel free to just jump in and begin answering.
I'm going to let Ruth start.
Okay, I can start. It's new, right? And they're still, I think I would say providers are still getting used to it and adjusting to it. It's complicated. CMS included this behavioral adjustment factor that does adjust payments based on agency behavior, which we don't think is necessarily fair to the really good actors. The adjustments are made regardless of whether the agency actually engages in the behavior or not. And that's maybe another example of a big hammer to control some bad behavior by some providers. But what about the real world? You know, what's happening in the real world, and could we test it that way? So I'll start with that.
Yeah, I guess I would just say, you know, we're so of multiple minds about this benefit, you know, so for so many years, you're trying to correct this problem that we thought there wasn't enough therapy being provided. So then we're going to pay on the basis of how many therapy visits are delivered. And then it just becomes a therapy at home benefit. So we shift gears and we come up with this person-centered sort of patient-driven model that in theory should be rewarding agencies who are taking care of more clinically complex patients and delivering more skilled services like skilled nursing, and those people also have very significant functional limitations, and yet we're not really seeing, like, at least I just feel like there's a mismatch between what we want to be paying for and what we are paying for. The best way to get more home health aid visits into the home health episode is to pay based on home health visits. So it's like, then as soon as we do that, we'll probably find the workforce magically will appear, and then we'll end up with a ton of home health aid visits being delivered. So I think this is a long way of saying, I think we have to stick with this, see how it goes, continue to monitor it, but maybe think about what else we need to do to essentially kind of move these agencies off this like dependence on therapists and into more about truly skilled benefit. And I'm sure some of that will be addressing workforce issues, of course.
Thank you.
I would just lift up Ruth and Ann's comments. And I don't know that I have too much more to add. I would just put a note at the end of Ann's comments about the workforce, as we've talked about it now. It seems to be like one of the major takeaways from our conversation. But one thing I would say is, yes, we need more workers. We also have to support the workers that we have, because it's not a sustainable job. They're undervalued and they're underpaid. And if you look at even, COVID-19, for example, we conducted a survey of home care agencies, Medicaid home care agencies, for the most part, during the pandemic. And a lot of the agencies don't have enough backup workers. They can't support the workers if they have to take time off. And that's just on a day-to-day basis. That's not, that was in COVID, but that's also something that a lot of agencies face as is. They don't have the benefits that you would need if your child gets sick or something. And so I think that the workforce issue includes supporting the workers that we currently have. Most of them are not making a livable wage. It's just not sustainable. And so, if we want to increase and so that makes it an easier job to leave. There's no incentive for folks to stay, unless you really, really love what you're doing. And so I just wanted to lift that point up, just to piggyback on what Ann said.
Perfect.
Very true. Thanks, everyone. So this next question now is, can you talk about what states might do either with or apart from CMS? And again, I'll open this up to anybody who wants to answer.
That's a good question.
Certainly training. Certainly during COVID, we saw some add-ons to wages, and I agree with Chaney. Wages are a huge issue. Probably, Anne referred before to some technology solutions. I suppose states could provide some of that. Obviously, we're talking about the Medicare benefit, and that's a federal benefit. So most of the change I think that we'd be looking for here would take some state support, but it really is a federal set of changes.
Yeah, I totally agree with Ruth, and Ruth, you just gave me an idea. So thank you for going first on that one, because you just gave me an idea, which is that states really need to educate themselves about Medicare. Dual eligibles are by definition eligible for Medicare. And I think, it's easy for me to say states are very busy and their resources are, I don't mean to be flip about this, but I will just say that there is a new office of, I think it's Medicare Innovation in California. So California as a state is starting to actually take the initiative to understand the needs of the Medicare beneficiaries in their overall population, not just dual eligibles, sort of with this recognition that, every Medicare beneficiary is a potential dual eligible if they finance, back to Ruth's point about long-term care financing reform, if they have faced catastrophic needs for long-term care. So, I think the state is like, and we've been providing some support for that, thanks to the SCAN Foundation. And I would just say, like, it's been a really interesting process of educating the state about Medicare beneficiary population, the use of home health services, how it varies by geography, even within the state, the referral patterns. There's a lot to learn and understand. And I think that's a really good starting place for states.
And I would just say, speaking of duals, that, there is the opportunity for states and CMS to be more collaborative, because a lot of folks transition from, that short-term Medicare home health, or need to transition from short-term Medicare home health to Medicaid home and community-based services. And that transition is not always smooth. If you're not already dually enrolled, or if there is a 7-year wait list for Medicaid home and community-based services, as is the case in some states. That's one of the things I think families don't understand, is like, at some point these services are going to stop, and then what do? Right? Because we have someone with a complex health condition. Okay, maybe they don't meet the criteria to receive home health services anymore, but now what? And so I think that there is a huge opportunity for state agencies and Medicare to sort of think more strategically about how to continue care once services end, once Medicare services end.
Everyone. So this next question again is from YouTube. In hospital, rehab centers, long-term care, and assisted living, space design is a significant factor in effective care delivery. How can home design for staff and caregiver safety be addressed as home care increases?
Sorry, I was just like, oh, that's such a good question.
It's a really good question.
Yeah.
Before we get to home design, and I was thinking this as Chaney was talking too, we need to get to home. We need to get to housing, because, and I know that that's not as complex as the lovely question that's being asked, but without a place to live in the community, you're not going to be able to get home health or home and community-based services or anything else. And you're going to be forced into other options, many of which may be the right one for you, but maybe not. And maybe it is possible for you to remain in the community. We have long waiting lists for senior housing, for affordable senior housing. We really do need to address those too. If you needed another problem, Lisa, I think you probably know.
I just wanted to talk a little bit about Capable, which was developed by Dr. Sarah Zanton here at Hopkins, and has expanded quite a bit. But Capable participants or clients or recipients receive occupational therapy. They receive therapy, but they also receive a handyman, services from a handyman or someone to come in and do some environmental evaluation and fix things around the home. And so that is one way that we can take, the home environment into consideration. The other thing is that we might take a note from a program like Money Follows the Person that transitions long-stay nursing home residents into the community. And a lot of people end up receiving grants or stipends to do larger bodies of work on their home, whether it's a ramp, whether it's something that's going to help them integrate back into the home. Because a lot of folks, the dream is to go home, but they just can't move around their home, and it's not as safe as it was before they left. So just to lift up those two programs, and notes can be taken from MFP, but I really support the expansion of Capable.
Thanks, everyone. So we now have 1 minute left. In this last minute, I just want to say a big thank you to each of our panelists, to all of our viewers out there, and to the Commonwealth Fund for their generous support of this work. If any of today's topics piqued your interest, please check out BPC's website for our new report titled Optimizing the Medicare Home Health Benefit to Improve Outcomes and Reduce Disparities. Thanks again, everyone, and take care.